So Dr. Lecia Sequist is an associate professor in the Department of Medicine at Harvard Medical School and attending physician in medicine at Mass General, just down the road. She's been in Boston a long time, Harvard Med School, then trained, as I did, at Brigham and Women's Hospital, did her fellowship at the Dana-Farber, and has been, I believe, since then at Mass General. And Dr. Sequist has been part of and leading the charge in acquired resistance basically along the whole time since these agents were showing their promise and then leading us to the frustration of acquired resistance. And in the last few years has been very important in teaching us about some of the molecular changes that occur in that setting. And one of the implications has been the potential utility of repeat biopsies. That's been an evolving field, and she will be speaking on that. And I will say that at this point, especially with some of the most recent work that Dr. Sequist has been doing, including presenting the data at ASCO on the Clovis agent that there will be some more discussion about, has fundamentally changed the value proposition of repeat biopsies. So I think this is really moving very quickly from an issue that only has been practiced in limited settings to completely changing our standard of care of how we approach acquired resistance. So let me bring over Dr. Sequist to speak herself on it.
Thank you to Jack and Jared and to everyone at Grace and Longevity for having me be here. I think this is a fantastic forum, and I'm so happy that you're all here today. It's great to see a couple of my patients and some of our other patients from Mass General, and I hope we have a great discussion all day long. So I'm going to be talking about repeat biopsies and how to take that information and use it. And because most of my research is focused on EGFR, that's kind of the basis of what I'm going to be showing you. But these are concepts that can apply to ALK, they can apply to ROS, I think they can apply to any targeted therapy. Next slide, please. So the way that I'm going to go through this story is a little bit historical and tell you how we all have gone along through these advances over the last 10 years. And so this is a slide of a CAT scan from the original discovery paper of EGFR mutations in the New England Journal 10 years ago now, showing how the cancer, which is here in the patient's right lung, magically disappears on gefitinib, which is one of the first EGFR inhibitors. And I put in the title, The Magic of EGFR Inhibitors. That's something that my mentor, Tom Lynch, who trained me and several other people in the room, used to say. And really, as oncologists, we did think it was quite magical when this first was discovered, because we just didn't see responses like this to chemotherapy. This was an entirely different, qualitatively different type of a response to treatment. And so that was the next slide, please, the basis of that slide. This is also an old slide that I made probably nearly 10 years ago, but I always like to show it. And what I like about it is that it's called the promise of genotype-directed therapy, because when we first saw those responses to gefitinib and erlotinib, we began to dream of this day when we might take a group of patients who all had the same diagnosis in the center of the slide, adenocarcinoma, for example, and we might be able to figure out which of them were in the green group or the red group or the yellow group or the white group and should be treated along different algorithms. And this was really kind of this concept, pie in the sky concept, which today, as you guys all know, is really the way we practice medicine. It's quite amazing that this thing has gone from a fantasy to a reality in such a short period of time. Next slide. So I like to use this analogy a lot when I speak with our fellows. And so essentially the concept of targeted therapy, and I know this crowd is quite knowledgeable about this, but I like this analogy. It's kind of like putting your things into a safety deposit box, your gold or your pearls, your valuables. And in order to get to your stuff in the safety deposit box, there's two steps. You have to have someone unlock the vault door for you, and that's this big, complicated door with lots of moving parts and pieces. And then you also have to have the specific key to your lockbox. And those two things will get you to your gold or your pearls. So in the analogy here, what we want is a CAT scan scan response like I showed you before. We want the cancer to magically melt away. But in order for us to get there, we first have to open the vault door, which is understanding the biologic context of that cancer. We have to understand how all the pieces fit together and what are the crucial key points in the road that we can block off. But even understanding the cancer is not enough. We still need the key to the lockbox. And in this analogy, the key to the lockbox is a drug that works in that particular scenario that you understand now, and a drug that is tolerable and safe for people to take on a chronic basis. So it's only when you have the great understanding of the biology and a drug that fits that scenario that you can have these magical responses that we've been lucky enough to see in many different kinds of lung cancer. Next slide, please. So on a more scientific basis, the concept of oncogene addiction, again, this is EGFR is just used here as an example, but very similar in ALK or ROS or many other genotype-driven cancers. Oncogene addiction is basically where, can you hit one more time, please? In a non-addicted cancer, you may have several different types of antennas or receptors that are lining the surface of the cancer cell, and all of them are sending signals down to the key downstream pathways which tell a cancer to grow and divide and spread. And so there's a lot of redundancy and a lot of duplicity built into the system. The system is much simpler when you have an oncogene-addicted cancer. In that case, all of these downstream signaling pathways are unusually dependent on one single antenna or receptor on the surface of the cancer cell, in this case EGFR. Next slide, please. And that kind of creates an Achilles heel, so that if you have a drug that can effectively shut off the signaling from that antenna, you can, in one fell swoop, cut off all of the downstream signaling so that the cancer just shuts down. And that's kind of what led to these, quote, magical responses that we hadn't seen the likes of them in chemotherapy, because the signaling in the cancer cells just completely shut off. That's what's different really at the core, I think, between targeted therapy and chemotherapy. Next slide, please. So the whole field was very happy with the notion of these new drugs, and we started to test people for EGFR mutations, and we started to treat them even before going to chemotherapy with some of the drugs we had at hand, mostly erlotinib in that day. But as has already been discussed, after somewhere like 1 to 2 or 3 years, patients develop acquired resistance, and that was of course, our next big challenge. So this is just a series of CAT scans of a patient of mine that show a larger tumor here and then a smaller satellite tumor. Her disease responded very nicely to the EGFR inhibitor erlotinib because she had the EGFR mutation, and you can hardly even see this little one. See, it goes down to this tiny, tiny dot. But over time, after about 1.5 years, it does start to grow back. And so I think, as Jack alluded to, this idea of doing repeat biopsies kind of came gradually, and it started at the academic centers and it's been spreading out. And at the beginning, it was really done for research to try and see, could this patient collaborate with us and help us understand what's going on the molecular basis inside the cancer right now. So here's a picture of this patient getting a repeat biopsy. Next slide. Because at that time, again, we had this fantasy or a promise of what could happen. Instead of the first promise I showed you, which was all the patients in the middle and the spokes kind of going out, and that was it, we re-envisioned a circular pattern that you could keep going around and around, where you would have a cancer, you would do a biopsy, you would run some fancy tests that look at the genes and everything inside the cancer, and that would instruct you on a targeted therapy. And then you would go around again. If this targeted therapy stopped working, you would do another biopsy, another analysis, and you could keep going around the circle. So the paradigm kind of started to shift from a one-time thing to an iterative type of process. Next slide. So when we first started doing repeat biopsies somewhere around 2008, there were, of course, different pros and cons that we had to weigh with each patient in front of us. And of course, the concerns were that there could be complications and, quite realistically, the cost. Would we be able to get these repeat biopsies paid for? The complications of a repeat biopsy vary widely depending on what part of the body you're biopsying and what type of procedure it is. There are several areas of the body that are fairly safe to do repeat biopsies on, but the lung, where lung cancer often is one of the more complicated areas. And that's because you have an air-filled organ with a tiny membrane, like a balloon basically, around it, and you're sticking a needle through it. So, I mean, you know what happens when you stick a needle in a balloon at a kid's birthday party. Here, you know, the lung isn't really a balloon. It's like a million of little tiny balloons. So, but there definitely is a higher risk of doing biopsies in the lung than other parts of the body because you might get an air leak. You might pop some of those little balloons. So the concerns were the complications and also the cost. And at that time, the benefit was really, like I said, to contribute to research, to understand with greater depth what was going on. How was this cancer that was so effectively shut down and all the signaling shut off, how is it coming back to life? Next slide. Oh, I wanted to just actually take this moment to say that it's a complete myth, in my opinion, that doing a biopsy causes the cancer to spread or grow faster. That's an old wives' tale that's out there. Many people are concerned about it. There's no scientific basis for that notion. Okay, next slide. So what we learned from several patients who generously went through repeat biopsies for the purpose of research is that in general, and again, this applies not only, I think, to EGFR, but also to ALK, which I think you'll hear about later in Dr. Doble's talk and Dr. Shah's talk. This is a general schematic of the types of acquired resistance to targeted therapy that we have seen in lung cancer. So at the beginning, we talked about this scenario where you have the receptor, the one that the cancer is addicted to, and you have all of the downstream signaling being effectively shut off by the drug. The drug is these little triangles, and these are the downstream signals, and these lines are dotted because they're turned way, way down or off. And what we've seen in the repeat biopsies is two basic types of resistance that come up. One is an alteration in the target itself, and the other is a bypass track. So what does that mean? Alteration in the target itself could be several things. It could be a mutation that makes this receptor or antenna on the surface of the cancer cell not amenable to being inhibited by the drug, or the drug can't bind to it anymore. It could be amplification, so kind of force of numbers, just putting out lots and lots and lots of the protein receptor so that the drug isn't physically able to shut down the signaling from all of it. Some kind of alteration of the target of the drug so that the drug is no longer effective and the signal comes back on. In EGFR, this is the most common mechanism of resistance that we see with that mutation T790M. There are mutations in ALK as well, multiple different mutations that can occur at crizotinib resistance, and you'll hear about that later on. So the other main type of resistance that we see is the development of a bypass track. So we talked about how at the beginning, when you have an oncogene-addicted tumor, that all of the downstream signals are very, very reliant on one antenna, like EGFR. But here, the cell is adapting and putting up another receptor tyrosine kinase, or maybe two others, that can, the drug here that you're taking is still shutting down the signal from the original receptor, but other receptors come in to take the place. They're not inhibited by the drug, so the signal comes back on. So these are the types of concepts that we've learned from doing biopsies on patients. Next slide, please. Next. I think what's next is a pie chart summarizing in patients with EGFR mutations the types of things we've seen. Next slide, please. So this is a summary of the first 100 or so patients that we biopsied at MGH. We're now almost to 250 with our cohort, but this is, as has been reported by many other groups, and I'll show you the memorial experience as well, half of the patients have an alteration in EGFR itself, which is this T790M receptor mutation. Then we do see some bypass tracks that come up, like BRAF mutations, MET amplification, PIK3 mutation, HER2 amplification has been described, which is not on this particular pie chart. And we won't talk as much about it today, but we have seen this unusual phenomena of sometimes the cancer transforms to a different subtype of cancer, small cell lung cancer, that still has an EGFR mutation. So that's a little bit of a totally different category. But next slide, please. Other groups, this is 150 patients from Memorial who had a very similar distribution, T790M. The target alteration makes up a big chunk of what you see in EGFR-acquired resistance, and then there are bypass tracks like HER2 and MET amplification, and unusually you may see some small cell transformation, and some of these can overlap and patients can have more than one mechanism. I think, I would say what we've been learning over the last year or two is that even these pie charts are somewhat of an oversimplification, and a lot of patients may have heterogeneous resistance mechanisms throughout their body, or they may have differences that occur at different times. There may be a dynamic shifting as you go through treatments. So it is hard, I think, to capture all of this at the end of the day in a pie chart, but for the moment, this is what we've learned, which is a tremendous amount in a short period of time. Next slide, please. So remember that we said that one key piece of this is having not only an understanding of what's going on, so opening up the vault door, but actually being able to have something to do about it, that key to the lockbox. You need to have an action to take or a drug to give. So where are we with targeted therapy using what we know from the repeat biopsies? Next slide. So a couple of different things with respect to EGFR-acquired resistance. One is this rare, but it does show up in about 10% of all series looking at repeat biopsies, that there's a transition to small cell. And patients who have this transformation do tend to respond very well to chemotherapy agents traditionally given for small cell, which is not something that would normally be given to an EGFR mutant lung cancer patient. So in that case, the biopsy really did change your therapy options. And this is a CAT scan showing a patient that had a large chest wall mass here wrapping around a rib and a lymph node under her armpit here that both got much, much, much smaller when the erlotinib was continued, but a different chemotherapy was added given the small cell transformation. Next slide. We've also seen that patients who develop, go ahead, next slide. Patients who develop the bypass track of MET amplification can respond to a combination of Tarceva plus a MET inhibitor. So this is a patient who started with erlotinib, had a good tumor shrinkage. Here's the needle going in for the repeat biopsy. Next slide. The repeat biopsy showed us that compared to the pretreatment biopsy, this is a FISH image. So you can see this kind of cool neon glowing in the FISH studies. There was just normal copies of MET, which is the red dots at the beginning, but in the resistant sample, you have a lot of extra copies of MET, which are these red dots here. And next slide, the patient was able to go onto a clinical trial that combined erlotinib with a MET inhibitor, and you can see that this tumor area that was biopsied shrunk way, way down on that treatment. And next slide, I think the most exciting thing over the last year are these third-generation EGFR TKIs. Dr. Yanni is going to be talking about that this afternoon, so I won't say too much more other than that when patients have T790M, they can go on these drugs, which are specific for T790M, and you can see here different areas of the cancer can get much smaller and go away when you use the repeat biopsy to direct your next line of treatment. So where are we in 2014 when we think about repeat biopsies? Well, we still have the concerns of complication and cost that we have to look at carefully. And I think we have a growing appreciation that there can be some heterogeneity in the resistance within the cancer, and that one small biopsy in one small location won't always tell us everything. Next slide. But I think in addition to being able to better understand the biology, now we can really say that this biopsy procedure may help you go onto a new therapy or help us together figure out what is the next best therapy given the context of your cancer at the moment. Next slide. So I think that the scales are really more than ever before are tipping in the direction of repeat biopsies are certainly worth it. And in fact, now repeat biopsies, at least the consideration of doing a repeat biopsy, is recommended by the NCCN guidelines, which is this set of guidelines that a lot of oncologists in the country look to when they're trying to figure out what to do with a patient. So one thing that Jack wanted me to touch on, which I will do briefly, is this idea of a liquid biopsy, because of course that could help take out the risk of the complications, the air leak in the lung that we talked about. So this has been a very attractive option. I would say that there have been an enormous number of papers published about this, and there's not one definitive technology or platform that stands out to date. There are two main ways of doing a liquid biopsy, which is just to say a blood-based test that could give you hopefully the same information. So one is looking for CTCs, or circulating tumor cells. Again, there are a variety of different platforms that have been studied, different technology platforms of how to pick out these very, very rare cells of cancer circulating in the bloodstream amongst a sea of normal blood cells, red blood cells, white blood cells, all of that. So there's a variety of different platforms. The sensitivity, or how good is the test at finding the cancer cells and giving you the right answer about something like the EGFR mutation status, ranges, of course, quite a bit from different papers, but it's generally pretty good. It's generally over 50%. It is not reliably close to 100%, which is what you would want. But I will say that we've always compared our baseline of how to tell how sensitive the test is to use the actual tissue biopsy as our gold standard. And what I was just saying a moment ago is that one small biopsy of one small location may not tell you the whole story. So now that we understand more about the heterogeneity of cancer, it may be that there is no gold standard, at least between the liquid biopsy and the tumor biopsy. It's hard to know. I think that the response to drug is really the gold standard that we're looking for. The other difference, I think, about circulating tumor cells compared to the next type of process that I'll talk about is that you can glean more than just the genotyping because you are getting whole cells. You can look at the histology, so you might be able to see things like the small cell lung cancer transformation or do other tests like FISH tests, and ideally, for research purposes, culture. That's one of the things that we're really hoping these repeat biopsies, either liquid or solid biopsies, will help us with, is being able to make a model in the lab, of the patient's specific cancer, have your particular patient's cancer growing in a petri dish so that you can really tell, is this patient likely to respond to drug X or Y? Next slide. The other type of liquid biopsy is to look at plasma or serum-based circulating free DNA. And so this is DNA that comes from when cancer cells have broken open and it kind of seeps out and is circulating free in the bloodstream. It's, in general, a less expensive and more feasible on a broad scale type of test, so it's very attractive. And again, lots of different groups have published about this. The sensitivity ranges in different papers, and some are generally lower than CTCs, but some are very high. There was a recent publication with sensitivity in the 90s. So I think this is a very exciting area. Next slide. And one that we need to keep our eye on, but it's not a part of standard practice yet. And ultimately, when we do figure out the best way to do liquid biopsies, the best metric, I think, will not be to compare it to the tissue biopsy, but to actually compare it to how people do with the drug that you're then selecting based on it, because it may be that the biopsy has some false negatives that the blood test picks up. So just to summarize what I've talked about, go ahead, next slide. I think that repeat biopsies of patients with acquired resistance will continue to greatly supplement lab-based research. We talked about how at the beginning, when we started trying to do this on a widespread basis, it was really more for research purposes, and that has clearly changed, but we will continue to learn more than we ever could by any other mechanism through biopsying our patients. In EGFR mutation-positive disease, at least, repeat biopsies are a very crucial way to dictate the best therapeutic option today. That's no longer a pie in the sky. That's here today. And going forward, we need to develop less invasive ways of assessing tumor genotype as companion tests to these new drugs. But I do think that repeat biopsies will always continue to have a place, at least in leading the research forward. I think that's all that I have. Great. Thank you.